Good morning, Mark.
Morning, Ziad. Do you see us? And do you hear us?
We see you and we hear you.
Perfect.
We love your glasses.
Well, they are my specific cath glasses, so they are so ugly that I'm sure that I'm not taking them home. We have 3 cases today. The first case will be putting in a valve in a patient after tetralogy of Fallot, but we prepared a small presentation, so allow me to walk you through the presentation first. The presentation? So first case is a boy. He's today 12 and a half years old, born with tetralogy of Fallot with a minute right ventricular outflow tract and a very small annulus. The surgeon did try with a double patch, so below and above the valve. Yes? Is there a problem? So the surgeon did try.
Seems that we have
this
some connection problem they had this morning.
But you see the slide? So the patient had a transannular patch and had severe pulmonary regurgitation. Next slide. Here you see the echo early this year.
So you saw that this is a 12-year young boy, status post-transannular patch for tetralogy of Fallot. Obviously has significant pulmonary insufficiency, and these are the echo images.
Right. And next slide. The maximal systolic frame.
By echo, the measurements, as you can see here, is about 24 millimeter.
Right.
Obviously, you know, this is as good as you can get from an echo. This is the MRI. His end-diastolic volume is 158 ml per square, so that's criteria number 1. His ejection fraction is pretty good, 60%. That's one of the best I've seen so far. But the regurgitant fraction is significantly elevated at 43%. Next. So this must be his previous cath. You can see that large outflow tract. And then this is balloon sizing, probably during simultaneous RV injection. There's a catheter in the right ventricle.
Show me the microphone. Do you hear me now? Do you hear me now? Ziad, do you hear me now?
This is one of the best tests that you can do to really get the size of the RV outflow tract, is by putting a balloon in the MPA and a catheter in the RV and inflate the balloon, occlude the RV outflow tract, and then inject and see what size you have.
Do you read me now? Ziad, do you hear me now? Do you copy? Next.
This is for the coronary. This is the laid back view, extreme caudal with a slight LAO angulation. You can see your left main LAD circumflex, they fill nicely, as well as the right coronary artery. So I think there is good distance from the RV outflow tract to the coronaries. Next.
And do you read me now? Do you read me now?
Mark,
yes?
Can you hear us?
I can hear you. I can hear you, yes. But apparently you cannot hear me. There is a...
So basically the indentation on the balloon was 22 millimeter, easy stretch to 25 millimeter, no coronary artery proximity. So the options are, we can discuss them now. So that, you know, at this current approved, valves, the only option, in my opinion, here is the Edwards valve, right? What do you think, Jay and Andrea?
I think there can be some options. The pre-stenting with some balloon expandable stent, and then put some adult valve, or the venous, if available, venous P valve can be a good option.
For the balloon expandable stent, what size balloon would you mount the stent, and what type of stent?
So the extra large size stent, any type is okay.
Any type stent is okay?
Yeah, I think the extra large size, for example, the Andra stent.
Is microphone working?
XL,
what? Is it working? Is it working?
CP stent, yeah. Andreas?
I think I might go for a 26 millimeter bib balloon, and I would take under stent, and then I would look, the length of the stent would, I'm not quite sure, I would have to see the measurements again, and then I would see where it ends, and if it ends, let's say, with a 24 millimeter internal diameter, you would have both options. You could take a Melody valve, or you could take a Sapien 26. So you would have.
So you would stretch the Melody up to that diameter. You would not.
Well, if I have a 24 millimeter landing zone, I think there's still an option for the Melody valve. But of course, the Edward Sapien valve in this case would also be a good option.
Great. Okay,
Does it work?
Next slide, or let's go live
Yeah.
now and see what
Next slide.
Mark is doing.
Slide, next slide. Next slide.
So this is the test that I'm telling you about. So with this, there is pretty much.
Hey, can you hear me?
So they put a 24 millimeter bib balloon, as Andreas
Can you hear
mentioned,
me?
24, 26, in this case 24, and he is doing the understent XXL 39 millimeter. So it will shorten to probably about 10-15%. So the stent looks in very good position. The branch pulmonary arteries are good, and it looks like it's fully opposed to the wall of the main pulmonary artery. In such cases, what I would like to do is flare up the proximal part of the stent in the RV outflow tract, so that when you advance the valve, you will not really have any problems. So let's see next slide, if they did that. So pre-stented 24 millimeter plus. Now, of course, there are options. As Andreas mentioned, they have the 26 millimeter or Melody 22 millimeter, and maybe go to enlarge it. It will enlarge to 24 millimeter outer diameter. If anybody from the audience has any question, there are microphones in the aisle. Please come in, introduce your name and your institution, and ask the question. So this is what Mark is doing at the bench to see his experiment. He wanted to fold the Melody. I don't know, that looked like the area is short to us. Andreas, did it look short to you that you need to fold the Melody?
Well, I think he's doing that to have a bigger outer diameter. If you fold,
Just for the outer
then
diameter.
you have an outer diameter of more than 1 millimeter more.
Yeah. So thicker stent. Yep. Do we have sound? Come back. Okay. Hear the heart rate. Next slide. Okay, we're back live. Mark, not to you yet. Talk louder. We hear you, but you need to improve that.
There are a few things I wanted to point out in the interrogation. So I think it is very important to do interrogation at low pressure, as you could see on the slides, where you could see the indentation. The angio already also showed that there was still valve tissue in the back of the outflow tract, and that is very reassuring because that will hold back any stent you put in there. Every time that you interrogate a patient with a transannular patch, if you push hard on the balloon, it will always stretch to almost gigantic measures. So the balloon occlusion with RV angiogram did show that we already, however, at 25 millimeter, we had a total occlusion. So now we have standard standard crimping.
So,
Do you
let
have?
me ask you a question. I mean, you prefer to do this rather than use a straightforward Edwards valve, 26 millimeter?
Well, both valves have their advantages and disadvantages. The Sapien would be 26 straightforward. The problem, as you already pointed out, was that you may have to open up the stent as you come in, because, as you know, you will enter the pre-stent with the Sapien valve unprotected. It may encroach to the stent, and that may be a problem. So, and the second thing about the Sapien is that the covering is limited, but we still have to make. Is the sound okay now? Okay.
Agree with you
So
on
that
the advantage of the melody being covered until you are the target lesion,
Right.
and that's actually is a big plus, because I tell you, the more you do Edwards, you will have at one point a case where you cannot get to where you want and you cannot get it out of your body.
Yep.
So it's either you have to deploy it somewhere or a surgical cut down or something.
Okay.
So we keep bugging Edwards to do a long delivery sheath, but they're not listening to us.
Now, and the thing that Ziad, you mentioned at the placement of the stent, you said you would have preferred the proximal part of the stent to be flared. I fully agree with you, but very often I am also happy that the stent stays in place and doesn't fly away. And so you really need guts and balls to manipulate that stent after placement in this situation. As a matter of fact, I have on Saturday morning I have a talk on embolizations of stents, and I will scare the hell out of you guys by showing examples what can happen if you fiddle around too much with the stent. So usually when I put this stent,
I agree with you.
Usually when I have to turn it a little bit. So usually when I put in that stent, I'm very happy to get out without dislocating the stent, and that's about it. Now the folded stent, in theory, you can put it.
Tell us, what are you doing now with this with the scissors? Are you cutting or just expanding?
Just expanding. It's not scissors. It's a kocher. So okay.
Not scissors.
Not scissors. Don't use use too strong ones.
Yep, I see it.
Because otherwise, so I'm just stretching this a little bit. You don't really need it, but it makes life a little bit more pleasant. I still need to make my angio, but okay. So you see there is quite a mismatch over here, and so we will have to push.
Yep.
Push, and this is actually the hardest part of the whole catheterization, is get this in there.
Mark?
Yes?
Can you comment?
Sure.
Hello, this is Andreas Eichen.
Andreas, good morning.
Mark, we use a PowerFlex balloon for this widening, a 10 millimeter PowerFlex balloon, just to make the comment.
So you balloon dilate the tip of the sheath, the covering, to expand it. Yeah.
Yeah. Now, so I was discussing the options with the. As I said, this can take time, but we can try the trick of Andreas with the 10 millimeter PowerFlex. And so I also will need an end deflator then to give some decent pressure. Of course, you will have understood by now that this is off-label use, but you don't come to the meeting to see on-label use.
That's good. Thank you for telling us this.
No, I managed, but it's still the second corner to take. So, just to do the arrhythmics, I did hear you guys speak about a melody on a 22 ensemble should fit, that you have doubts about a 24 millimeter tube. Let's put things straight. If you deploy a melody valve on a 22 millimeter ensemble balloon, the outer diameter is 24. Full stop. Yeah. And I must say, if Medtronic can change something about their labels, it's probably the arrhythmics on their label of the melody. Because they're suggesting that the melody has a thickness of 0.0 millimeters. If you see this, you know that's stupid. And so when you speak about a Sapien 26, it means that the Sapien 26 is 26 millimeters outer diameter. Outer diameter. When we speak about a 22 millimeter melody, we mean inner diameter, and the outer is then, the valve is sliding a little bit. I will need to, sliding. Can you inflate the outer balloon a little bit?
And that retract the cover when you are at the target lesion?
Say it again. Outer, yeah.
Have you encountered any case similar to what you're doing now? When you are at the target lesion, you cannot uncover the valve?
No. I mean, uncovering. Okay, and now you go first. Here. Uncovering the valve even in a curved
Uncovering
situation.
is easy.
Not easy. It takes some strength.
No, it's not easy.
And
and
especially
we had problems to uncover the valve, but it always worked. But it was difficult in cases.
Yeah. So I have some trouble with going with the covering here over without and not moving the valve. So I'm trying to push it. Okay, there we go. This should work. Inflate the outer. Just have to immobilize a little bit the outer. Not too much. Deflate a little bit. Okay, we are in position. We're good.
Great. Okay, good. We're there.
We still have to make first our angio, but allow me now to go to the images that we have seen so far. So can I get the review in the fast the A screen? The review. Give the review A. Review A. So this was this morning.
Yep, we see that.
We crossed it with a balloon-tipped catheter. As you can expect, the worst thing you can do is enter the stent by a side hole. So using this balloon tip technique has two advantages. First of all, you miss the tricuspid valve or the chordae. And second, you enter the main entrance of the stent and not a side entrance. The next will show you. Then we're looking for a vessel, a place as distal as possible. As you know that putting in the valve can involve some fiddling around with the valve.
Mark,
I think yes. Yes.
You prefer to put the wire in the RPA, not the LPA, or it does not make a difference in your hands?
I allow the balloon to make his choice, and so I know we can have a whole discussion on left or right. In my practice, I see what the balloon does. If he wants to go right, I take right. Now in this case, okay. I think that the...
Andreas, where would you like to put the balloon?
I think the most stable, as Mark says, sometimes it wants to go left, sometimes it wants to go right. It just should be, you should work time and really spend time to have a perfect position of your wire.
But let's say that you can achieve perfect position with both positions. Is there a preference for you, LPA versus RPA?
My preference would be LPA because then the course of the valve going up is more straight.
Correct.
But on the other side, I think what Mark is doing now is perfect.
Okay. Jay?
I think in this patient, I noticed that the right low part of proximal part of the stent was a little bit protruded from the RVOT. So in this patient, I think our right RPA may be better.
Okay.
So
okay, Mark, please continue. We have about 10 minutes with you for this case.
Okay. there's a few. So in this case, I think going into the left PA would be a problem because of the angle of the stent, the outflow tract towards the left PA. But okay, show the hands. Now the second thing that I like very much is get a stiff catheter and preferably pre-bended in the pulmonary artery. My hands are here. Now the way we do it over here is, as you saw, I did use a Thermo exchange on the balloon-tipped catheter, so that allows us to steer it and things like that. And now I'm going to use, I want to use a stiff, pre-bended E-wire in the pulmonary arteries. The E-wire is almost the same as a Lunderquist. However, as you all know, pushing a pre-bended wire through the heart is annoying, because typically it will pull back the catheter and you may end up with everything falling into the right ventricle. The trick we use now is we take a 6-French right coronary guiding sheet. So the guiding sheet that the coronary people use to implant stents, I will take this over the Thermo exchange wire. We dry it up in the meantime, so I still have. And so give live FOS. Give live FOS, camera. And so you will see that typically the Thermo wire is stiff enough to take.
Can he move?
To guide the.
Move the box of you. Yeah, thank you.
Okay.
Go ahead.
So you could see that there's the Thermo exchange gives enough support to get that right coronary guiding sheet in place. Now that guiding sheet is big enough to take 2 wires. So now I can put my other wire next to it, but I will pre-bend it. Now the reason why I pre-bend it is I like to use this wire as an anchor into the pulmonary circulation, and I want a little bit simulate. Can you show me my hands in the full screen? So you see there's a good pre-bend. It's almost impossible to get this pre-bend through a regular catheter in place, because you always will yank out the catheter from the pulmonary arteries. However, you now will see that going next to this wire into the rather stiff right coronary guiding sheet, it should be a piece of cake. FOS, show big screen. Yeah, so we're getting there. Agree that is easy. We remove the Thermo and we remove the right coronary guiding. And now we have a very stable position of a stiff wire through the outflow tract. This has the big advantage that this wire will allow steering and an easy placement. If you look on the FOS, for instance, if you look on the FOS live, we're live again now. You see, if I push on this wire, I will push the wire to the side. However, if you pull, you easily can pull him into the middle, and the distal part did not move. Well, try this with a straight wire, and all of you will know that if you pull on a wire that is straight and pushing against the outer wall, he will come out. And so if you do that...
Can we proceed, please? We have a few more minutes left.
Okay.
To San Donato.
Okay, I first need to define my landing place, so we're going to make an angio over there. I go in with multi-track. Kunnen we koppelen aan de pomp? Niet te ver, gewoon in de uitvoer.
What's the purpose of the angio? You said,
just to define my landing place. I want to see, and especially if you use a sapien, that's extremely important. Where does the stent touch the wall? Because if you put your stent in a position where there is a possibility of paravalvular leak, we're going to give 30 at 25. If you put the stent at a place where there is a possibility of a paravalvular leak, you will have a paravalvular leak. So I want to put the stent somewhere in the stent, but at least where there is a full apposition or adherence to the stent. We will put the FOS in cranial position.
Keep going, please, while you're talking. Keep going while you're talking.
And we just go a little bit cranial, as perpendicular as possible to the stent, so that we have a good image on that. Perfect. Okay, we can make the angio. Is de blaas op? De blaas is op, hè? The lateral is alright. Okay. We can still. So you see, I will need to put them equal with the distal part. So you need this angio as you could.
Can we see picture the frontal and the lateral instead of your pictures, guys?
Okay. Can you show the picture? So both the two radio pictures, the lateral and the A and the B. Laten we weer doen.
Thank you.
So this is, you see.
Play back the angios, yeah.
So you see on the proximal, if you would put your stent, if you would put your stent on the dilatator, yeah. If you would put the stent in the proximal part of the stent, and you don't, yep. What?
We lost transmission again.
The valve is almost in place. Just a second. We pre-dilate. Okay.
Okay, Mark, we're listening.
So I'm gonna try to put the stent equal to the distal half the distal half of the stent, so that the distal ends of the melody and the stent will almost superimpose. Okay, that's the aim. It's always nice to say your aim in the beginning. Okay, we go in. We go in. Our patient is awake. Patient is awake. Please make him sleep. Just a second.
That's not the right time.
Oh well. They keep him in a mild sleep, so we're not expected to make him hurt him, but entering the ensemble in the groin is not the best thing that can happen to you. Yeah, knife.
What size sheath, Mark, do you have in the groin? You said 24.
No, we have no sheath. We enter the ensemble with its own
sheath.
tip.
You're gonna go through the skin.
Yes.
That's probably why he's feeling it.
Yeah.
I usually give Marcaine at the beginning of the procedure, which is a long-acting
Got it.
xylocaine that helps these patients.
Yeah.
Now you can see he's a bit tachycardic.
Okay, valve comes in. Valve comes in. Okay. So we go in.
Can we move the box, please?
Ontspan. See the melody is slightly anterior on the.
It goes very nicely.
Yeah, but the melody is anterior. Can you show the picture on the left side?
Can you tell the photographer if you are removing that box and show us the lateral?
This is the lateral, but my melody valve is too anterior on the balloon. It's not good.
We can't see the lateral.
Show the lateral, show the B, show the B. We komen weer uit, we komen weer uit. Okay, we have a problem that you see now. The advantage of the new ensemble system is that the valve is slightly.
But it's okay. He can inflate it.
Well, I'm gonna get out and reposition the melody on the balloon. The balloon is too distal. The melody is too distal on the balloon. It's not safe. It may embolize distally. So we come out again with the ensemble. We come out with the ensemble, and I just open it a little bit and
you want us to go back to San Donato and then come back to you?
Okay, perfect.
So thank you so much for this nice demonstration, for the puncture and for what you're doing. This is very exciting. So we're gonna go back now to Leuven to see what Mark did with that valve. Let's go back to Leuven, please.
Okay, do you hear me? Zia, do you hear me?
Okay.
Yes.
Mark?
Yes, do you hear me? Do you hear me? Ziad, do you hear me? Ziad?
Yes, we can hear you now.
Okay, perfect.
Yes.
Can you show this one? So what I did, I pulled out the valve just to reposition it a little bit. The valve actually was all right on the balloon. The thing is that with all the manipulations, the balloon had stretched a little bit. The markers are on the sheet and the balloon is the balloon. So I did do it a little better. As you can see over here now, I see also the distal markers like that. You are sure that, are we seeing the right thing? Yes. So
Yes.
right this, you are sure that the balloon is well positioned on the valve. The next shows then, and I think it's a lateral. It is a lateral, go to lateral. Here we are uncovering the melody valve. As you said, I was aiming to get the distal ends of the stent together, just to keep me sharp. I always agree with myself where to put the stent, and I aim to deliver it within the millimeter that I intend to. So this is just pulling it back. I must say it went rather easy, not difficult at all. I mean, the fact that it was double folded didn't matter too much. By the way, when I repositioned the melody and go covering it again, that went very smooth. So once it is well crimped, it goes easy. And then the next will show you that inflation of the melody. So that's a typical inner outer stuff. I think you all know that.
Yep.
There we go. That should be it. Yeah, there we go. Inner, outer. And there it is very important to keep pushing until you see the stent of the melody being completely opposed to the previous stent. Now, this is a bib balloon, so the ensemble mechanism is bib. That means 22 bib. If you push it a little harder, easily can go up to 23 without a problem. The next, I thought it was all right. But if you look, can you give also the A? Can you give also the A? Yeah, you see at the left inner the A, yeah. At the, or both, but especially look at
the frontal.
The frontal, I mean it's the cranial. It shows that the left inner curb is not completely opposed. So I did reinflate.
Can you make the frontal bigger?
Yes, go back one. And this big, this A big, yes.
Yeah.
I mean, it was probably
Yes,
already good, but now it's better. So I reinflated my ensemble mechanism like this. Looks good. And then we made the angio. And I presume this is catheter-induced pulmonary regurgitation, but we'll check it this afternoon by echo.
Yes.
As you know, as long as there is a catheter going through the valve, you will expect always some leakage. So the points I wanted to show was get the arrhythmics straight. 22 millimeter melody fits in a 24 tube without a problem. If you push a little bit harder, it's 25. If you need extra safety, just go for a folded mechanism. I think everybody will have seen how easy there was progress of the system with a pre-bended stiff wire. It's definitely my preference, but in order to get it there, you may need a little trick like we used with the 6 French guiding, right coronary guiding sheet. And I think, an interrogation of the outflow tract is crucial. You need, if you see some valve leaflets, if you see some indentation, that is reassuring. Then at full inflation, if you see no contrast going around it, that is also reassuring. And that was what tripped me off to proceed in this patient, and I think with optimal hemodynamic result. That's it.
Great, thank you, Mark. We're going to take questions. We have somebody on the podium. Is that John? Microphone on the aisle, please, there. Good. Yes. Go ahead, John.
Now it's off? Okay, good. Mark, John Cheatham. Just a couple of comments, and because you were using the new ensemble balloon delivery system that has markers as opposed to the old one that had no markers. So I was just wondering, because you have to do a fair amount of manipulation when you fold the melody like you did. You went from a 33, 34 and expanded to 22, but you have to do a lot of manipulation, and you had to make the outer covering bigger. Do you ever, just like we do with bibs in general with stents, do you ever fluoro it to make sure you're exactly where you want to be, as you have made so much manipulation, and then the first time in it was too far? That was the first comment. And the second thing is what Ziad was, the question he asked you is what sheath do you have in? Because I think that one of the things that we've started to do is starting to use the Gore dry seal sheath. Like, for instance, the standard ensemble, not what you just did, it goes through a 22 dry seal sheath, so we never have to change, and you have no resistance when you go through the skin. This would probably be a 24, and then we do this also for the harmony. So it's just to eliminate any pressure going through, because the system's bigger now. But mainly just do you check before you go in to see if there's going to be it's perfectly on the balloon before you go in, so you don't have to take it back out again?
Well, to be honest, this was my 4th new ensemble system. So I'm an old guy dating from the days that there were no markers. So there was nothing to check in the old days. And
Mark, I mean, in this case in particular, this shows the importance of the marker. When the stent moved, if there was no markers, it would have been, I'm sure probably you would have detected that, but would have been harder.
Yes, but as a matter of fact, when I checked it, the balloon was reasonably well put on the melody was reasonably well put on the melody. What I saw was the markers are on the shaft, and the whole balloon system had shifted forwards. The melody had not shifted on the balloon. So I think that it was probably still good enough, but I felt more secure by checking it and looking for the markers. But point taken. Now with the new ensemble system, it is an extra safety you can add, and although I must admit this is a melody number 220, something like that, I have never ever had the stent move distally during deployment. I've never seen it. But an extra safety will not hurt.
Great.
And then the other question was the dry seal. Again, we've done over 200 melodies right now this way, and it will not add to. It will add to the speed. It may add to the easiness. It will also increase the cost. In Belgium, for the reimbursement system, we are on a tight schedule. So doing it the way we did is all right. Once you start with the dry seal sheet, that cost will make us go into a deficit. To get an advantage, which actually will, in the long run, doesn't make a difference. I haven't seen problems with the groin. I haven't seen problems with the vein. And the thing also, the way we close it, so we neutralize the heparin at the end of the procedure, but before I take everything out. And then we just typically will put one Donati suture. A Donati suture, I don't know if you are acquainted with that technique, but it's where you go with a needle deep, and you come back superficial. So this, with one stitch you have good deep compression. So with one stitch you have both the skin and the deep compression, and we remove that stitch after 1 week, and I must say it gives a good hemodynamic and a very good aesthetic result.
Okay. Last question by Andreas.
I would like to make a comment on the dry seal. I think it makes sense to have a 24 dry seal in the drawer, Mark.
Oh, we have it. We have it in the drawer.
If you have a problem with the melody valve, you can get it out through a 24 dry seal. So it makes sense for those who implant melodies to have a 24 dry seal in the drawer.
There, I fully agree. The thing is, Andreas, you are also a proctor. I'm a proctor. I think everybody on the panel is a proctor. And the most embarrassing thing that can happen to us is go to a center where they will have just and no more than the equipment that you need to put in the valve. But once you start running into trouble, you need big sheets, and not only a 24, even a 26, bigger sizes. You need a lot of equipment. Safety equipment in a cath lab is very important.
Last question.
John, that was fantastic. I want to ask Andreas on the balloon expanding the tip of the ensemble sheet. What size and what high pressure? Because it may actually have an advantage on dilating the tip of it and prevent the migration of the valve. So what balloon and how much pressure you put in to dilate it?
Well, doing this folding is the idea of UNES, and we've done 14 cases now using this folding technique, and it helped to take 10 or 12 millimeter PowerFlex balloon because you get an even dilation of the cover, and it's not so dangerous to make an incision, you know, it doesn't. So we use a 10 or 12 millimeter PowerFlex balloon for this.
Okay. One brief question, go ahead.
A short question about the last image. I think we saw some leakage, could well be of the catheter. One thing we must sometimes use is intercardiac echo to check if the valve is perfectly all right, if you're in doubt. Do you have experience using it, or what's your...
Thank you. Brief answer, Mark.
You must be a very rich boy in a rich country. We use intracardiac echo if it's a real indication. In this case, we take all the catheters out and we'll do a transthoracic echo this afternoon, and we will come with the same information.
Mark, thank you so much. Wonderful case. Thank you. Congratulations.